just a couple of slides on the background, just to make sure we're all roughly in the same place. So what are we talking about? In terms of fungal infections, there's a variety of fungal organisms there, which Candida and Aspergillus are numerically the most common throughout Europe, across the various largely hospital settings. In terms of mould infections, it's Aspergillus. So invasive mould infections, Aspergillus probably represents, across the board, somewhere around 70 to 80% of all detected mould infections. And I'm not going to address the other infections on, the other organisms on this sheet. Now, this is a bit difficult to read at your back. The scale of the problem. Now, it's probably fair to say that fungal infection in general, worldwide, is a hugely neglected area. And the numbers on this slide show you that for the invasive infections that I was talking about on the previous slide, worldwide estimated life-threatening infections are huge. And this estimates, the publications on the bottom, if it's not projecting very well, it's Science Translation Medicine 2012, and if I recall, the first author is Mike Brown. These numbers are likely to be huge underestimates. Now, the final column shows you the mortality, the range of mortality associated with these infections, and I'm just going to focus on the setting here of the patients who are most at risk of invasive fungal infections in general, including invasive mould disease. And you can see the different settings across the bottom, so leukemia and bone marrow transplantation, so-called, other forms of solid organ transplantation, and then immune depression with retroviruses at the end. And this crude mortality rate shown here, as you can see, goes upwards from 50%. So these are in patients who have good evidence of invasive aspergillosis. So in this setting, if patients get invasive mould disease, the outcomes are likely to be poor. So I'm going to present, so that's just a little bit of background. I'm going to present a few slides about strategy, because strategy is important in this setting, and the terminology behind the strategies that I'm going to refer to. So there's a bit of jargon, I'm afraid, in this. The current challenges that I think have been current for rather a long time, the only thing that's possibly changing in terms of current challenges is the emergence of resistance in invasive, well, in fungal organisms in general. I'll say a little bit about what treatment options we have, and then specifically mention a recently licensed agent, Isavuconazole, which is really the first new agent we have in this area for almost a decade, nearly a decade, and then finish with stewardship, but stewardship with respect to antifungal stewardship. I suspect everyone in this room, I assume, is familiar with antibiotic stewardship, antimicrobial stewardship, but antifungal stewardship is again a largely neglected area in just about every NHS trust where this could be relevant. So strategies. So we have a number of strategies we could use in the high-risk populations that I've referred to. And the first point to start with is prophylaxis, primary prophylaxis. And really for me, primary prophylaxis is the only term that I think we can easily define, because that's very simply, you give a preventive drug, you hope, to your population that you think is at high risk of the problem. So that's easy. Everything that comes after primary prophylaxis is up for grabs. It's really not easy to define, and I hope that will become clear during the talk. Empirical treatment, I will say a bit more about that on the next slide. A preemptive treatment, sometimes referred to as screening, makes the assumption you have some tests that you can do to help you make a diagnosis before clinical signs and symptoms appear. Okay, and again, I'll discuss that a bit more detail on the next slide. Now, the later patients start treatment, I haven't put the references on it, but I suspect at least some of you will be familiar with the data from invasive candidiasis in ICU. Well, there's very good data showing that delayed treatment, in fact, beyond 12 hours, is associated with significantly worse mortality, and there's similar data for Aspergillus infections as well, but not from ICU, from a hemato-oncology setting. But the point about this is, as treatment's delayed, outcomes are worse, and what we really don't want is to be treating patients at this stage where we're very confident that we know what's going on, because that's almost always too late. So what does empirical therapy mean? So it's really very simple, but very clearly defined in the literature at least, which is probably not clinical practice. Empirical therapy means you have an at-risk patient, so generally a neutropenic patient who has persistent fever despite broad-spectrum antibiotics. And you don't do any tests, you react to that clinical scenario and start antifungal drugs. That is empirical treatment. Okay. Is that clinical practice? Probably not. I'll come back to that. Screening or preemptive strategies assume, as I've mentioned, you have one of these tests available to you and you use them on a regular basis in your at-risk population. So this will be an inpatient population, be it in ICU, be it in the hematology unit or elsewhere. And the tests shown there are all commercially available. GM stands for galactomannan, which is more or less Aspergillus specific. Beta-D-glucan is a pan-fungal assay, and PCR, commercial PCR, is available for Candida, debatable how useful it is at the moment, but also for Aspergillus. You perform these tests regularly during the inpatient stay, and the whole idea is these tests hopefully will become positive before waiting for the clinical signs and symptoms. Okay. Now, this is probably where there's most focus in terms of current management strategies, is diagnostic, so-called diagnostic-driven approach. Now, this is actually identical to an empirical approach. What triggers the performance of diagnostic tests is the patient's clinical signs and symptoms, which is in this setting, as I've mentioned, is usually refractory persistent fever. But you don't start a drug. You perform some tests. Yeah, so that's really, in a nutshell, the difference between a diagnostic-driven strategy and the empirical approach. And the tests you perform are the same tests in terms of biomarkers that you may have used in a screening strategy. And in a diagnostic setting, you will also perform imaging. And that imaging is typically a CT scan of the chest, because invasive mold disease is principally an airways infection, the lungs and the sinuses in particular, from which you get hematogenous spread to any organ of the body, potentially. Another point to note on this slide is you can, if the CT scan indicates a pneumonic process, perform a bronchoscopy. And on that BAL fluid, it's very well established in the literature, is a better tissue to be testing than serum or blood. Now, we all like testing serum and blood for whatever we want to diagnose because it's easy, but unfortunately, as I've just mentioned, these are largely infections of the airways, and the blood is not the ideal material to use. What we don't get is culture and histology. So it's very rare in this patient population for us to get sterile material from the lung to either prove histologically or grow these organisms. So we don't prove the infection. And you'll see the significance of that as we go along. So challenges, well, the challenges undoubtedly, and I think hopefully you're getting a feel for where I'm going to, is diagnosis. We cannot easily make a diagnosis in this patient population. And the diagnosis is really built on these three arms. You have a patient at risk, you have some clinical signs. Now, the clinical signs that are accepted in terms of international criteria, there's only one, and that's imaging. So, and of course, I don't need to tell an audience like this, an image doesn't tell you what the pathogen is. And that's something that I think as clinicians, managing the patients in front of us, we tend to forget. And then there are a variety of laboratory tests that could be used, and the reality is that in the UK, The biomarkers I've mentioned, there are also other biomarkers we could be using, are not routinely used, they are not routinely available, and the turnaround times in the centres that use these tests are often inadequate for clinical management. So that's a reality of life on the ground, even in the UK. So there are some challenges. These are the only definitions we have of invasive fungal disease. The so-called EORTC MSG criteria, updated in 2008. I'm sorry I haven't put the reference on the slide. Its first author is Ben DePauw, published in 2008 in Clinical Infectious Diseases. So if you want to look at it in more detail. But very simply, as I mentioned earlier, for a proven infection, so we can be sure we know what the patient has, we need tissue. And that tissue is either a biopsy or it could be an aspiration from a sterile site, which we do not get very often in these patients. So the vast majority of the literature and clinical practice is based on a lower definition, lower evidence of the presence of invasive fungal disease. So probable is regarded as the three factors I mentioned as being present: host at risk, imaging, and a mycology result suggesting a fungal infection. So that's probable. Now, if you have all of that, you have host, you have the imaging, but you don't have any mycology, microbiology evidence of a fungal infection, that's a possible, according to these criteria. And then the logic of that is that if you have mycology by itself, so you've got an at-risk host, you have, let's say, a galactomannan positive in the blood without imaging evidence, that doesn't count in this criteria, in these criteria. So there's a problem with this, of course, because that patient may have invasive fungal disease, we don't know, but the criteria will score that as not positive. So that's what we're dealing with, and this is a reality of trying to know what's going on in our units. So we took these criteria, so this is a bit of local data, just to give you a feel for what you might find if you go looking, at 531 episodes of intensive chemotherapy for leukemia, or patients who were receiving an allogeneic transplant, to see what was the incidence of invasive fungal disease using these criteria. And you can see here that we found our probable proven rate to be 2.1%. Now, if you are familiar with this area, you might feel, well, that seems very low, or you might feel that seems about right. Basically, we don't know. That's what it boils down to. And even if we include the possibles, we're at 7.4%. Now, if you look at this, anyone want to have a guess at what this number represents? 44%?
Was that had it and were not treated?
Yeah.
People had it and were not treated?
Okay, so that's almost there. Good guess, almost there. No, this represents, in this patient population, the percentage of patients who were treated for suspected invasive fungal disease. So it's quite obvious that there's a dichotomy between what we can establish using criteria of invasive fungal disease and our treatment rate. And a treatment rate of 44% in this population is actually low. If you look at what goes on in many hematology centres around not just the country, but around the world. So this is the problem. The problem is we can't easily make a definitive diagnosis, and so as clinicians, we're worried about our patient, so what do? We treat. Yeah, and we treat because of the data I showed you earlier, that delayed treatment is associated with increased mortality. Yeah, okay. So this is, for me, our daily clinical practice. Is what I call the empirical reality. So we're faced with a patient who we think has invasive fungal disease. Yeah? So, there's some evidence to suggest the patient might have invasive fungal disease, but we're not sure. And because we can't easily make a diagnosis, we don't identify an organism or even biomarker evidence of what the pathogen might be, our practice is almost entirely blind. Okay, now there's another consequence of this. In the same data set, I just want to show you where we spent our money on antifungal drugs in terms of patients who did or did not have invasive fungal disease. Because, of course, there's not much point in using antifungal drugs if the patient doesn't have invasive fungal disease. It might seem obvious. So it's the same data set, but you can see here that using those criteria that I've just talked about, we spent almost all of our money, £1.35 million, on patients who had no evidence of invasive fungal disease. So there is a consequence for our being wedded to empirical treatment. You know, I don't think it's tenable that we as clinicians can keep doing what we're doing, be it in hemato-oncology, be it in the intensive care unit, be it in other settings. The other aspect then I was going to talk about in terms of current challenges are resistance. So resistance is probably something much more an issue in the terms of invasive candidiasis. Now this is a slide from the IDSA guidelines published in 2009, and what I just want to emphasize here is that when you look at these candida species, there's well-established potential resistance to the azole drugs, which you can see on the slide. The details are really not important. And on the final column is the sensitivity to, which way am I going? There we go. Is the sensitivity to echinocandins, shown there. So you would reasonably use an echinocandin as first-line treatment for invasive candidiasis until you know the specificity or the species identification, and if it was one of these organisms, then you would stick with an echinocandin. However, life isn't that simple, and in the same table, if you were dealing with a parasilosis, then you would have to have some caution about using the echinocandin as your first-line treatment. And a footnote to the table said that at this point in time in 2009, that resistance to Candida parasilosis was rare with respect to echinocandins. Uncommon was the phrase used. In 2012, the ESMID group published their latest Candida guidelines, and although they recommended echinocandins with an A1 grade for invasive candidiasis, they specifically mentioned, this is only 3 years later, that you needed to know your local epidemiology, and if you had rates of Candida parasilosis that were of concern, then you would probably not use an echinocandin in that setting. Because in fact the data suggests patients respond better to fluconazole in that setting than to echinocandins. So the point around this is resistance is occurring with the medications we have. This is Candida. I know it's not mould. And this is just a bit of data from post-marketing experience with echinocandins of patients who started treatment with an echinocandin for invasive candidiasis and had breakthrough candidemia. So what you're seeing here is, this is time across the bottom, this is the number of candidemia breakthroughs per year, and what they found in this post-marketing surveillance study was that the breakthroughs, 50% of these breakthrough Candida infections were with parasilosis. So it just emphasizing that resistance is occurring in the fungal world. So what about, there we go, what about mould infections? So this is a slide provided for me by Professor David Denning in Manchester, and you have time across the bottom, and these are Aspergillus fumigatus isolates at Manchester showing their resistance to a variety of azoles. And the only thing I want to emphasize is that in 2014, that part of the bar chart represents pan-azole resistance. So it's important to be aware that the population in Manchester that they're studying is a specific population which is not the population that tends to get invasive mould infections. It's a population with chronic airways disease due to Aspergillus. But nevertheless, there is emerging and spreading resistance in Aspergillus. This is a multi-center, a multinational study looking at resistance amongst Aspergillus isolates. So there were nearly 3,000 isolates, nearly 1,500 patients involved, and in this data they were able to establish that just over 350 patients had Aspergillus disease as opposed to just having an isolate. And just for the sake of time, I'm only going to focus on those of these patient group that had invasive aspergillosis. And what you see here is that 10 patients, well, 10 isolates were resistant to were antibiotic resistant, antifungal resistant, and 185 were sensitive. So that gives a resistance rate of 5.1% for fumigators in invasive aspergillosis. Now, when you talk to clinicians, most of us say we've not seen a patient with resistance. And I suspect that's because we don't isolate the pathogen, so we can never test the pathogen. So this growing resistance is going to become a problem in the field of Aspergillus, in the field of Candida, for invasive fungal disease in general. This was largely a European study, so this data comes from across Europe, and although I've not shown the data, azole-resistant Aspergillus infections have a much worse outcome, and in some series, mortality is 100%. So it is a major problem if it happens. What about our current treatment options then for invasive mould infections? So this table summarizes a variety of international and national guidance with respect to the various drugs available to us, and they're very simple because they all say the same thing. They give an A1 recommendation to voriconazole for the treatment of invasive aspergillosis, and they all recommend as an alternative liposomal amphotericin. So that's straightforward. When you look at the pivotal data on which voriconazole was licensed for invasive aspergillosis, it was done against conventional amphotericin, and there you can see the outcome data showing voriconazole is superior, both in terms of response rates and survival at 12 weeks than conventional amphotericin. But if you look at the data in this way, so the green bar is voriconazole in terms of the primary outcome, then there's still almost half of the population who did not have a successful outcome. So the point being that we have better drugs than we did 10, 15 years ago, but we don't have an armamentarium that's going to solve our problems at this point in time. So Isavuconazole, I mentioned it earlier, is a newly licensed azole for the treatment of adults with invasive aspergillosis, but also for mucormycosis, in which we have very limited treatment options if amphotericin is inappropriate for some reason. And I'll just take you through this data fairly quickly. So this compares voriconazole, currently regarded as being the first choice for invasive aspergillosis, against isavuconazole. And you'll see if you look at all these various parameters here, that isavuconazole performs better than voriconazole. So for example, if you look at food effect, so that has a significant influence on voriconazole, and some of you may be aware even more so on another azole, posaconazole, then that's not relevant to isavuconazole. The bioavailability of isavuconazole is better than voriconazole. If you're using the intravenous formulations of these drugs, then isavuconazole does not contain cyclodextrin, which is an issue in patients with renal impairment if you're using voriconazole, and so forth. Of course, there's one big difference with advantage going to voriconazole is we've been using voriconazole for a very long time and are familiar with it and know how to use it. Isavuconazole, clearly, we have yet to get experience with. So this was the pivotal study for isavuconazole, randomization against voriconazole, and the primary objective was all-cause mortality at 42 days. So not about response rates, it was are you alive or are you dead? So this slide simply shows that in terms of the primary endpoint, there was no difference between the two drugs, and that's shown in a different format, both for the ITT and the MITT populations here. No difference between the two drugs in terms of survival, either at the primary endpoint of 42 days or the secondary endpoint of 84 days. There were differences between the two drugs in this study, and they all come in terms of side effects. So if you look at this table, then study drug-related adverse events were lower in isavuconazole, and similarly, drug discontinuation was lower in the isavuconazole arm. And rather in keeping with that is adverse events attributable to the medication. You can see basically the two drugs are extremely well balanced, but where there was a statistically significant difference, isavuconazole has less side effects than voriconazole. And probably the two principal things to note here are in terms of visual hallucinations and flashing lights are much less frequent with isavuconazole, and a lower rate of liver dysfunction, which can be an issue with all the azoles. Okay, so the guidance as exists at the moment for the treatment of invasive aspergillosis is, as I've stated, voriconazole or liposomal amphotericin. At the moment, the isavuconazole data is too new for any of the existing guidance, but ESIL 6, so one of the European bodies that publishes guidelines on infection, and ESMID guidelines about to come out on aspergillus will both be recommending isavuconazole with an A1 grading based on this study. So just a quick word about mucormycosis. Okay, a rare disorder, but nevertheless, when we see it, it's extremely difficult to treat. This was an open-label study of a variety of invasive fungal diseases, and in this study there were 46 patients who were treated for mucormycosis with isavuconazole, of which 21 had isavuconazole as their primary first-line treatment. And once again, the primary endpoint of the study was all-cause mortality at 6 weeks. Now, what this slide shows you is data in terms of mortality related to mucormycosis infection in published studies in the literature, in an online registry of invasive fungal disease run by, out of Cologne by a colleague, Professor Cornelli, a meta-analysis using all of that data, and then finally the data with isavuconazole from the so-called VITAL study. And basically what you see is that if you look at all the patients treated in the VITAL study, that's their mortality rate. For those patients treated as primary therapy with isavuconazole, you can see the result there. So this data, if nothing else, is entirely comparable with existing data and suggests that isavuconazole does have a role in the management of mucormycosis. I'm going to finish then with stewardship. Can I assume that everyone in the room is familiar with the concept of stewardship? Yeah, I assume so. So I have got just one more slide on what is stewardship. So this is antimicrobial stewardship. And I think the American CDC summary definition is rather nice and just about says what we mean by it. You can all read it there, but it's worth me reading it out. I don't like reading things off a slide, but this is a slight exception. So the right antibiotic for the right patient with the right dose and the right route. And interesting, they say, understandably, causing least harm to the patient and to future patients. So in other words, what they're getting at, of course, is resistance and the development of resistance. Antifungal stewardship, in principle, is identical. You simply replace the word. There is no difference between them. But there are very few centres in the UK that I'm aware of that have a true active antifungal stewardship programme. I showed you some numbers earlier about cost. So, what would be the driver for having antifungal stewardship either as part of or as separate to antibiotic stewardship? Well, it's not just cost. As I've shown you earlier, it's a lot to do with best management, because at the moment, best management involves clinicians giving antifungal drugs because we're worried, not because there's good evidence the patient has an infection. So I'm not going to go through this in any detail because this will be something that you are all familiar with if you're familiar with stewardship, because it applies to the antifungal arena just as it applies to the antibiotic arena. Of course, education, absolutely key, and it's a big problem. It's a big problem in any setting because of the relatively high rate of turnover of junior doctors, because of resistance from, let's put it like this, senior medical colleagues who don't see the benefit of better advice because they don't think it's better. So it's the same for antifungal management. But perhaps a thing that's a particular challenge in this area is local data. what actually goes on in your hospital, in your unit. Just as the epidemiology of fungal infection is a challenge, because we don't identify the pathogens very often, especially for mould infections. So I'll just show you a little bit of data from our centre on the impact of diagnostics. So in 2012, we introduced this as our management strategy in hemato-oncology. We identified patients who were at risk, specified what prophylaxis we thought was appropriate, and we had a trigger time for performing fungal diagnostics at 72 hours of persistent problems. And our diagnostics were really quite straightforward: a CT scan of the chest or of some other part of the body if clinically indicated, and galactomannan done on 2 consecutive days. So that was what we said we would do. The clinical team was supposed to wait for the results of these tests before starting an antifungal drug. Not easy to do in clinical practice. We're trigger happy with our prescriptions. And the variety of results that you could get out of that diagnostic strategy was supposed to determine what you did. I can see some of you straining to see all the things, I think partly because the screen is low and we are relatively high. I'm very happy for people to have these slides made available to them afterwards. It's not a problem. Either contact me or the meeting organisers. Okay. We did an audit a year after introducing this policy to see what had happened with the fungal diagnostics. And this was just done in a subset of patients, I won't go into this, who received mycofungin. So that's a detail I don't want to focus on. So in this subset of patients, there were 19 episodes of treatment for suspected invasive fungal disease. And you can see there that 4 of these patients simply didn't get any of the tests that we said we should be doing, a CT or a galactomannan. And 4 of the patients did get a CT and galactomannan testing, but after starting antifungal drugs, which is not bad. I don't have a problem with that. The whole point about this is do the testing. If you're worried about the patient, start whatever you think is appropriate, but do the testing and then come back to it once you have the results. But did we come back to it? Not really. 15 out of these 19 patients had no evidence of invasive fungal disease using the EORTC MSG criteria. So even in a unit like ours, where we think we pay attention to this detail, we can make significant improvements over and beyond the introduction of diagnostics themselves. And how can we do better? Well, very simply put, it's stewardship. You do need a team of people to address these issues in order to avoid what's still going on. And what's still going on is that doctors are being they're being driven by the patient's fever. Because the patient has persistent fever, well, we've given broad-spectrum antibiotics, they're already on an antiviral drug, perhaps it's fungal, let's start treatment. And that is what's happening on a routine basis in many centres around the country with no evidence that the patients actually need these drugs. Okay, so this is, I think we're still okay, 5 minutes to go. This is a clinical case, and I think the aim of this was to show you a couple of things. One, the diagnostic process, if you're not familiar with it, that goes on at least in the sort of patients that I'm looking after, and where stewardship potentially could have helped if we'd had it. So this is a gentleman who was neutropenic, he had respiratory symptoms, and he had a CT scan that looked like that. And this would be suggestive of an invasive mould infection. It would be compatible with that. He had some biomarker testing done in his serum, which was negative. He had a bronchoscopy, and on that BAL fluid, he had a series of diagnostic tests done, which were all positive for aspergillus. So galactomannan, a pan-aspergillus PCR, and the test I haven't mentioned to you, an aspergillus lateral flow device assay, which is about to become commercialized and is a rapid laboratory test for invasive aspergillosis. They were all positive. So on the basis of that, we would say, according to the criteria, he has probable infection, and he was treated appropriately. I've just shown you what the guidelines say. He had voriconazole, and he had liposomal amphotericin, not at the same time. This gentleman was discharged and came back a month later unwell with respiratory symptoms. He was still neutropenic. This was a CT scan. And he had all his diagnostics repeated, and now everything that had been positive was negative. But the clinical management was perhaps not quite what you might guess from this. It was his fungal disease is getting worse because he's come back. He has a CT scan that looks like it could be invasive fungal disease, so we better change his fungal treatment. We'll give him 2 antifungal drugs. I mean, why give him 1? He's getting worse. Let's give him 2. Whereas, if you look at this in this way, with the scans next to each other, and considering the change in the diagnostic information, I suspect a team, a stewardship team, may have suggested to the clinicians, you know what, his fungal lesion is getting better. Yes, it looks like invasive fungal disease, but it's quite obviously responding to the treatment that he's on. All your markers have gone negative. Perhaps there's something else going on. So, and if you look at criteria for what it's worth, these criteria are not for clinical use, but he's now downgraded to a possible. And the clinical decision that was made on this was clearly not the right decision, not least because I'm afraid this gentleman died. But when he died, the fungal lesion had virtually completely gone. So his fungal lesion was always responding to his antifungal drugs. So these cases require people with expertise. It would be a pharmacist, it would be an ID physician or a clinical microbiologist, and someone from the relevant unit, an ICU physician, a hemato-oncologist, to be part of that team. And I think cases like this could be managed much better with stewardship in place. This is a rather extreme example, has to be said. Okay. So just my final summary slide. I think I've shown you, and I suspect you're all aware, invasive fungal disease in this immunocompromised patient population is a life-threatening disease. There is a huge problem with diagnostics, and because of that, there is this constant strain between empirical treatment with all its consequences, which is over-treating a huge number of patients who do not have the infection, plus the cost of the drugs, plus the toxicity of the drugs, which is not benign. I've mentioned local epidemiology, which is a challenge, and we do need expert input into managing these patients with the emerging resistance in both Candida and Aspergillus species. And I've mentioned antifungal stewardship. So I'll finish there with this rather beautiful painting. It doesn't always project as well as this, but it's a lovely room to project a painting like this. This is very near where we're all sitting. It's 10 minutes away. So if you want to do something in your lunch break, enjoy a little bit of art, I can tell you where it is. You might be able to guess. It's not very far. Thank you.
We have got time for just 2 questions.
Oh, sorry. I think there's some roaming microphones.
The misuse or misdiagnosis is driven by ethics rather than...
Sorry, I missed that. Just to repeat that, sorry.
The misuse of the antiviral drugs, people just misdiagnosing, is driven by ethics. Too scared not to give them.
Oh, okay. So the question is, are we simply too scared to not give antifungal drugs in this case? And that's what's going on. The answer is yes. You know, as I said, the fear factor it overrides any data around is this infection present. And in an antibiotic scenario, and I'm sure you're all familiar with the difficulty of getting antibiotics stopped at a time when it would be reasonable to stop antibiotics. And in the antifungal arena, that's even more of a heightened problem. Because once you start an antifungal drug, you didn't have good evidence to start it, it's going to be very hard to know when to stop it. And in general, what happens is these drugs don't get stopped until the patient has had recovery of their neutrophils, their fever's gone, and they're better. Now, if that takes 2 weeks or 3 weeks to come out of their aplasia, the drug will be given for all that length of time. And I would hope most of us have accepted that's not a good way of managing antibiotics anymore in a patient who's become afebrile, even if they're neutropenic. But for antifungals, people will just keep going. So yes, there's a huge amount of work to be done there, and it's going to be by people who have an interest in the area, people who have some expertise, to provide that support to the clinical teams, because they will not voluntarily stop these drugs. All right. I think one more question maybe, and then I think you've all got to. There's another session now, isn't there? I believe. There was a question at the back. Oh, so did you? Oh, okay.
Thank you. Thank you very much. I'm from Portsmouth, Sarah Wiley, microbiologist there. We were sending you blood for a triple test.
Indeed.
To diagnose invasive aspergillosis, but I gather that's been withdrawn. Is that true?
Okay, so I mentioned the triple test, but not by name. So PCR, pan-aspergillus PCR, this Aspergillus lateral flow device, and galactomannan. We were offering at Barts Health NHS Trust with Public Health England a service for centres that wish to use it to provide those 3 assays on material sent to us. And I have to say, at the moment, we cannot offer that service. I think for those of you interested in fungal diagnostics and who think it's relevant to your practice, it certainly will be if you have solid tumour transplants or hemato-oncology patients. Then there is a national study that's potentially going to open up later this year using a battery of diagnostics provided in the context of the study. So if that's of interest to you, then again I would say please contact me. I'm looking for centres who wish to be involved in that study. There are 2 potential national studies, one for intensive care, which is run by Dr. McMullen in Belfast, so he would be the person to contact, and one in hemato-oncology, which is being led by myself, so depending on your patient population.